Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more. Hi everyone, I'm the Millennial Mechanical Therapist, and today I want to talk about why using mechanical diagnosis and therapy in the extremities is just as good an idea as it is using it in the spine. The spine has always been characterized as having non-specific low back pain or non-specific neck pain, things like that. Identifying the pain generator using a pathoanatomic diagnosis has been a problem for a while. Trying to cluster together test findings and using CPRs to identify the structure at fault causing all that pain has been very difficult for many clinicians, especially new grads, trying to get that to be a comfortable thing to get through during your assessment. The good news is that using a classification-based system, perhaps using a symptomatic patient symptom-based response method, can help you classify that patient into a category, which then guides your treatment protocol. So you kind of take some of the guesswork out of the way. My challenge to everyone kind of working and out doing clinical duties is, why isn't that a similar situation in the extremities? Most of the literature coming out lately is kind of questioning the validity, the specificity, the sensitivity of most of those orthopedic special tests that for so long we've relied on to create a pathoanatomic diagnosis or a provisional classification to work on and guide our treatment protocol from that. Now, we often find that a clinical prediction rule or a cluster of findings is needed to rule in or rule out a diagnosis. Whereas if we apply the same principles that we use in the spine for that quote-unquote non-specific low back pain, if we just change low back to shoulder, we can do non-specific shoulder pain. Someone comes in with a painful arc, well, let's take them through a mechanical assessment first and see if perhaps they fit a derangement syndrome category and have a rapidly resolving condition with the use of an appropriate exercise in their direction of preference. Some of the latest research coming out involving NDT in the extremities is demonstrating that up to about 30% of those folks coming in with extremity difficulties and conditions actually fit that derangement syndrome classification. Now in that research, they also included patients who were post-op, so that kind of brings that percentage down. If we exclude the post-ops, which fresh out, status post day 3, things like that, we can obviously rule them out of a derangement classification. If we take more of our insidious onset pains, things that don't have a true trauma to them, the percentage of patients that fit that derangement syndrome category actually goes up to about 50%. So it seems to me that it would make sense to give them a fair shake at seeing if they fit that classification in the derangement syndrome. Now, going through your assessment to find that out should be just the same as doing it with the lumbar or the cervical spine. You listen to their history, you be interested, and you'll be better than like 80% of the people out there. If you're just interested in what makes them better, what makes them hurt, what does this, what does that, from there you can kind of gauge a little bit of a sense of where you want to go with the treatment. But ultimately, your repeated movement section of your assessment will help you identify that directional preference if there is one. The good news is that if you go through that assessment and you don't find necessarily the right directional preference for that patient, perhaps they fit a different classification, such as contractile dysfunction, which pathoanatomically is kind of similar to your tendinopathy, whether tendinosis or tendinitis. Additionally, it could be an articular dysfunction in terms of a contracture or things like that, certain tissues limiting the available range of motion and disturbing the biomechanics of the joint, causing pain. And ultimately, there's always room within the classification system to consider the other category, which would fall into using those orthopedic special tests to try to find out if this truly is a rotator cuff tear, if this really is a bursitis, things like that. Those pathoanatomical diagnoses do exist. Don't get me wrong, I'm not trying to say that those aren't real. I'm just saying that perhaps the derangement syndrome is a little bit more prevalent than we really think. After all, that is the great mimic of everything in terms of symptoms. The key component of identifying a derangement in the extremities or in the spine is the variability of that condition. Ultimately, I think that going through an assessment for someone with pain, regardless of their anatomical location, whether it's back, neck, shoulder, knee, hip, ankle, we would do best by our patients to give them a full mechanical assessment, trying to find out if they do fit that quick resolving derangement syndrome or if we do need to truly strengthen things, go along those lines. With that said, folks, move early, move often, and move to end range, because that's where the magic happens.